Okay, so this is going to be a discussion of certain topics in pediatric nuclear medicine. So it's an update. So first we're going to talk about gastrointestinal pediatric nuclear medicine, and a few topics in MSK, and then a few topics in oncology, so looking at MIBG and neuroblastoma. So first case is looking at a patient, a 2-week-old boy with jaundice. We can see that there's, in this particular case, that there's a lot of background that's not cleared well. It's evidenced by seeing urinary activity relatively early in the study. The patient also has, we can see that there's uptake in the liver, but not very much excretion in the bowel in the first 60 minutes of imaging. However, on our anterior 4-hour images, we do see activity in bowel, and therefore we've excluded biliary atresia, but this case is most compatible with neonatal hepatitis. So going on to this next case, we have a 1-month-old boy with conjugated hyperbilirubinemia who has good uptake into the liver. However, there's poor background clearance. We see cardiac uptake and blood pool uptake throughout the duration of the 60 minutes of imaging, and no uptake in the bowel, or no passage of tracer into bowel throughout 60 minutes, and none at 4 hours, and none at 24 hours. The findings are, in this case, most compatible with biliary atresia. So, postulated causes for neonatal hepatitis as an entity are infectious agents such as toxoplasmosis, hepatitis A and B virus, etc. Metabolic factors such as alpha-1 antitrypsin disorder, or inborn errors of metabolism or syndromes can do it. Other syndromes, genetic syndromes and idiopathic causes, are thought to be underlying predisposing causes toward neonatal hepatitis. But neonatal hepatitis, as we know, is not just an isolated entity. It's actually a continuum in which it's thought to exist as a continuum with biliary atresia, where biliary atresia represents sclerosing cholangitis of the extrahepatic bile ducts, and in particular, leads to congenital obstruction of the extrahepatic bile ducts, and is not a single entity. It can involve the intrahepatic, extrahepatic bile ducts to some extent, with various combinations thereof, and cirrhosis does develop if it is not treated soon in the patient's in a very early age, within the first couple months of the disease entity. So the treatment of choice would be the opavo-entero huginostomy. So next case is one patient's given pertechnetate, and they're looking for a Meckel's diverticulum. We see gastrointestinal activity evolving over time, and a focus within the right lower quadrant, which does evolve over time. So it should be fine at this point. However, we do see that the activity in the right lower quadrant doesn't seem to be there on subsequent imaging, on post-void imaging. On lateral images, it's kind of disappeared. So what's going on here? Well, the patient was brought back. The test is reattempted with the patient on H2 receptor blockers. And we see here that the finding in the right lower quadrant was indeed present, and this finding was in keeping with Meckel's diverticulum, and with positivity after the H2 receptor blocker. However, there was this situation where it wasn't positive, where it kind of disappeared, and so this entity, well, here's the CT, which was done for confirmation of the existence of the Meckel's diverticulum. Now, fading Meckel's diverticulum has been described, where they kind of disappear over time, and possible reason might be that the activity from the diverticulum was eluded due to peristalsis. The activity became diluted and sort of was no longer evident at the site of the Meckel's diverticulum. Here's another situation where there's a focus of activity that develops parallel to that of bowel gastrointestinal activity or gastric activity. We see the focus in the pelvis, and it was seen to move on cinematographic imaging. It didn't stay in the same location. In fact, it's a little bit lower here on this set of images. Just a second. A little bit lower here than it was on our initial set of images. So it seemed to move over time. And you may have seen these sort of bounce around. And this particular one was found to be, seen to be more positive on the 24-hour images. And it was found to be an enteric duplication cyst. An enteric duplication cyst is a relatively rare entity, but it occurs usually in the ileum. It can occur anywhere in the gastrointestinal tract, though. And it's one of the causes of potential bouncing around of the Meckel's diverticulum, because there are other possible reasons for seeing this sort of floating Meckel's diverticulum as it's being described. Possible unnoticed patient movement, could be movement of bowel, or maybe in this case a mobile duplication cyst. So Meckel's diverticulum, as we know, is a congenital anomaly. It represents incomplete closure of the omphalomesenteric duct and occurs in approximately 2% of the population. The most common anomaly of the GI tract. Most are asymptomatic, and the symptoms involve, when they are symptomatic, GI bleeding and peptic ulceration, and it can lead to obstruction as it may function as the lead point for an intussusception. So the symptomatic ones contain ectopic gastric mucosa, which are capable of producing hydrochloric acid and pepsin, and they can cause ulceration of gastric and adjacent ileal mucosa. Peptic ulceration causes acute GI hemorrhage in children, and they can be quite small, the Meckel's diverticula, which is why they're not really well identified on anatomic imaging such as CT. Protectate can accumulate in multiple types of entities, such as enteric duplication, intussusception, inflammation, IPD, vascular malformation, ulcers, and some neoplasms. So pharmacologic options that we have to invoke if we have an equivocal situation is to give an H2 receptor blocker or pentagastrin. H2 receptor blockers typically increase the delivery of protectate to the site of the Meckel's diverticulum it actually prevents the protectate from being eluted away from the site of the gastric mucosa, and pentagastrin allows there to be greater uptake of protectate at the site of the ectopic gastric mucosa. So now I'm going to go on to some musculoskeletal cases. So here's a 12-year-old female with back pain, and we can see that there's focal activity here at L3 on the left side. So one might think, okay, well, this may represent, might think that this could represent spondylolysis. However, because it's higher at L3, it's not likely to be spondylolysis. You can see it on SPECT imaging at L3 on the left side, kind of posterior, but it's thought to be more in keeping with an osteoid osteoma because of its location. It's a benign skeletal neoplasm of unknown etiology. It can occur in cortical or cancellous or periosteal bone. Cortical bone is most common, and can involve any bone. 2/3 involve the appendicular skeleton. Pain is usually worse at night, relieved with some small amount of aspirin, and 90% of patients between the ages of 5 and 25 years old. So here's another situation of a 15-year-old girl with back pain. She's a skater, and we do not see any abnormality on our planar images. However, on our SPECT images, we do see increased activity at L4 on the right side, corresponding with the pars interarticularis, and therefore it's most keeping with the stress at the level of the pars interarticularis. So next is we have an 8-year-old girl with leg pain. We see increased activity on the blood pool images in the left distal femur. See increased activity once again on the bone scan images in the left distal femur, and what's interesting is we see now a lytic lesion in the left distal femur radiographically, and in this case it likely corresponds with an osteosarcoma. Great way to image the extent of disease is PET FDG, PET CT, and here's an FDG PET image of whole body sort of chrome or MIP, in which we can see the increased activity at the level of the left distal femur. But we also see this activity in the left proximal left femur. What this represents is a skipped metastasis. Now, skipped metastasis is something that occurs within the same bone, or can occur across the adjacent interarticular joints. But we saw it here in the proximal left tibia, that would be a skip metastasis as well. However, if you had a lesion in the wrist, and then you had another lesion somewhere in the shoulder, for example, that would not be skip metastasis. Interestingly, it was present on the bone scan, the skip metastasis, but it's not all that evident. And we could also see it on the radiograph. So what's its significance? Well, it usually, skip metastasis is associated with worse prognosis than just a regular met or would be. So at least it's thought to be. And one that's actually, skip metastasis that occurs across the joint is thought to be worse than one that occurs within the same bone. So osteosarcoma is the 8th most common form of pediatric malignancy. The metastases around the knee are involved in about 60% of cases, and skip metastases are associated with their worst prognosis. Next, we're going to look at MIBG and neuroblastoma. I-123 MIBG is a normal distribution of involving the nasal mucosa, the salivary glands, neck tissues such as ground fat. You can see some increased diffuse lung uptake is normal. Myocardium is seen, liver, adrenal glands, gastrointestinal tract, and other urinary excretion is normal as well. So here's some neck uptake adjacent to the trapezius muscle, representing ground fat, commonly seen in winter months, and we do see this in MIBG. And here's some normal tracer distribution, a little bit of lung uptake. We see heart, we see liver, and we see some salivary gland uptake, and notice that there's some uptake within the diaphragm region as well, urinary excretion. So MIBG is a norepinephrine / guanethidine analog. It's concentrated by a neurotransmitter containing granules in adrenergic tissue. It has a high sensitivity and high specificity for detection of neuroblastoma, and it has this great advantage of not being taken up in the bone marrow very much. And in fact, if you see bone marrow uptake, it's usually abnormal. A little is maybe okay, but for the most part, unlike, it's very good at imaging bone marrow, unlike MDP, in which you limit, it's better for imaging cortical lesions, so they're complementary that way. FDG PET, on the other hand, has difficulty within the bone marrow because of its diffuse uptake within the marrow in normal cases. So cases of altered biodistribution can occur with extensive or hyper-avid neoplasm, can occur because of medications, suboptimal labeling process, or in renal failure. In the case of a suboptimal labeling process, it may represent too little MIBG, or it may represent elution of the I-123 from the MIBG. And here's a case of altered biodistribution in the case with a patient with stage 4 neuroblastoma with bone metastases. We do see increased activity within the cranial ball, throughout all the bones, and we see intense activity in what is thought to be the primary in the right adrenal gland. And the activity in the primary is so extensive that there's less activity seen in liver. We're seeing less normal liver uptakes and so forth. And here's a patient who was on antihypertensives, and we do not see that we see alteration in the normal biodistribution. We do not see any salivary glands. We see no heart, and we're not seeing any liver. And so the patient was on labetalol, and that was cause for reduced uptake. So a number of medications can reduce the uptake of MIBG, such as labetalol, metoprolol. So you know the list of tricyclic includes tricyclic antidepressants and multiple other medications. The most common in pediatrics, though, is when a patient is on cold medications such as pseudoephedrine. So here's another situation with a patient who had hypertension, presented with hypertension, and has cardiomyopathy, and had negative contrast-enhanced CT imaging, but they underwent MIBG imaging to assess for potential underlying neuroblastoma or failed chromocytoma. In this case, there's no cardiac uptake, and this patient was on calcium channel blockers, which can limit cardiac uptake, and it's known to do so in this case, but it could also be for other situations, we can do it. Medications, cardiomyopathy, congestive heart failure, being on a post-cardiac transplant, or high circulating catecholamine levels, which can occur in failed chromocytoma, it can also be a cause for the reduced cardiac uptake. Now, when do you use MIBG or FDG or indium 111 octreotide? Well, I-123 MIBG is the main sort of tool for analyzing or assessing disease in neuroblastoma. It's used at diagnosis and interval follow-up, including prior to bone marrow transplant and after bone marrow transplant, for staging, assessment of response, screening, and assessment of relapse of disease. F18 FDG may have some applicability in suspected false negative tumors that aren't taking up MIBG. And then also, in about 5 to 8% of cases that have been treated with MIBG, there may be dedifferentiation and no longer expression of MIBG may no longer be able to take up MIBG, and then would show more uptake of FDG, and that may be a more appropriate imaging modality. Sometimes indium 111 octreotide can be considered low-grade disease that's not MIBG added. And here's an example of a case where the patient had disease before, but then was treated, was suspected to have recurrence, and underwent an I-123 MIBG study, which was negative and didn't demonstrate any uptake or any abnormality or significant abnormality. The patient then went on to have FDG, or to have PET imaging, which showed extensive disease throughout the abdomen and elsewhere. With that, I'll end this update. Thank you very much.